All right, so let's do our last OB lecture.
Is this really the last one?
This is the last.
As nice and slow as we did on.
That was nice.
I only have 55 slides, so. I do want to remind you that your ATI proctored exam is the 24th at 3:10, right?
2:10.
2:10?
Well, that's what I have wrote.
Yeah,
2:10.
I like 210.
2:10 to 4.
2:10, it is 2:10, okay? You have to have your practice A done before the proctored, and I do not require any minimal remediation. However, I do highly encourage you that if you feel like you need to go and look back, please do so. All right, and then we'll finish up with this content today, and then your exam for last week and this week will be on Tuesday. Is that still good for everyone?
Tuesday at 4 or 6?
Tuesday at 6? 1800? All right. So, we're going to talk about, okay, so the little section there in Chapter 30 about common nursing diagnoses for postpartum assessments and teaching needs, you guys can look over those. You do pretty good with your care plan, so just look over those. So nursing interventions to promote comfort, rest, and well-being in the postpartum period. Please just kind of look over that. One of the things I will add that I gave this question back to you on the last exam is the one where the gal is saying what she can do for her perineum for comfort, and she could take ibuprofen, she can do something else I don't remember, or she can take a bath, which is a correct answer.
But it doesn't say SISBATH or whatever. That's
No.
what threw me.
So we don't really do sitz baths anymore for some reason. So we just tell the patient to go take a warm bath to help her perineal discomfort, as opposed to a sitz bath.
I thought it would increase infection.
That's what I
Yeah. So that's why I gave it back, because I didn't clarify that really well. In the book, it says something about, a warm bath with, not a big jacuzzi or anything like that, but just a little soak. Because we know that we don't put surgical incisions in a bath. That's what we instruct patients, and especially for our C-section patients, we tell them a shower, not a bath. Okay, so it was kind of a bad question, so I gave that back to you all. Anyways, so read this little section. These are going to be most of our slides right here. Excuse me. There's a little section on the postpartum family and teaching, so just look through that. I think this last exam you guys will be more happy with.
Oh, good.
There's not a lot of crazy stuff on this last exam. Look over the care of the woman with the C-section birth, and remember her care is basically the same as a woman who has had a vaginal delivery, except now she has a surgical incision. And so we need to instruct her to not take a bath with a C-section incision, to look for signs of infection, and then the rest that goes along with the vag exam. She's also, just because she's had surgery, she's at increased risk for, post-surgical atelectasis or pneumonia, and DVT. She's at a higher risk for DVTs because she had surgery. And remember, a pregnant patient being pregnant is being in a hypercoagulable state, period. Okay? So now she had been pregnant and delivered, and now she's had a surgery, so she's at increased risk for DVTs. So look over that section. Look over the little section on adolescence and in the postpartum period, focusing on her developmental level, basically. So she's going to have the same stuff, but just with the added complication of developmental level and nutrition, okay? Because the complication with adolescents, besides their developmental level, is they're still growing as well, okay? So their nutritional needs might be a little more demanding than a normal, healthy 20-some-year-old. Okay, there's a little section in there on relinquishing newborns. These beautiful women need some good care as well, okay? And maybe some psychosocial support. There's a little section on obesity and disabilities and women who have had sexual abuse. And so they each present their own little complications to pregnancy and postpartum. The one thing I'm going to say about sexual abuse is that this pregnancy might not be related to the sexual abuse, but because of the dynamics of pregnancy and childbirth, historical things may start coming up, okay? We had a patient who was married in a very great relationship, very supportive husband, having her first baby. She was sexually abused as a child. We could not examine her. We could not examine her. We could not do a vaginal exam on her. It was painful. It was excruciatingly painful and emotionally traumatizing. So we never checked her cervix through her whole labor. So anyways, very interesting. And
Did she have a vaginal birth?
she had a vaginal birth. She had no problems with her husband and their sexual relationship, just us being strangers, going down there, set her off into a stressful, physically and emotionally stressful event.
Do they address those types of things in prenatal care, or sometimes it's never brought out by the patient?
I'm sure that in their prenatal care that, well, I'm not sure. I don't remember particularly, but I feel like the obstetrician, that maybe they had that conversation. I don't know. Because it's part of their questionnaire.
And maybe in that relationship you had time to establish the trust in
Right.
the relationship, where not in the labor and delivery.
Right.
Okay.
Right.
So how did that manifest? Is she just scream at you guys not to, or like?
Well, I think the first time that we tried to check her, we didn't really know, and when we went to check her, she just tried to bite her lip and get through it. But it was so physically painful for her that we couldn't get it done. And then eventually, and then she kind of broke down, and then it all kind of came out. And then, I think we tried even one or two more times after that to check her, and we just decided it's not worth this. And the baby's going to come out, irregardless of what we know about her cervix. So, and she had a vaginal birth, but yeah, it was pretty traumatic for everyone, because if you're the person standing there eliciting these feelings from this woman, you kind of feel a bit responsible, and you feel terrible. You're not responsible, but it was hard on everybody at that time. Oops. I think there's a little section there on lesbian mothers. Really, nothing different, just because daddy is also female. All right, they get the same education, they get the same support. If they feel they need a little more emotional support, then give it to them, whatever they need. But usually, and we've had some lesbian couples who have come through our delivery room, and it's all great. But anyways, see what they need. Topics related to postpartum discharge. So usually in the postpartum period, we give patients this booklet, New Mommy booklet or whatever it's called, and it has everything mom needs to know about taking care of herself at home and taking care of baby at home. And then as the nurse, we sit down, we go through that booklet with them. They also have a DVD that they can watch, but basically we just need to let them know about their lochia, what to expect from their abdominal cramping, what to expect from their episiotomy, and its healing, signs and symptoms she needs to report. If this is a woman who had blood pressure issues during labor and pregnancy, she may continue to have those during the postpartum period up to about 6 weeks. So if she's a diabetic mother, we need to educate her on if she needs to go home on insulins or if she's diet controlled. So just whatever your patient's specific situation is. And then we'll do teaching on that. And then the newborn teaching, newborn care, and the signs and symptoms for them to be aware of as far as reporting to the doctor. So just read over that little sections. Very easy and comprehensible. Now, home visits in the postpartum period. So every patient has the option of having a public health nurse come see them after discharge. It's a free service, and they have to give consent for us to, of course, pass on her information to the public health department. And some patients strike through it and say, no, I don't need that, and some patients go ahead, most patients actually go ahead and fill it out. Because the public health nurse doesn't go see every single postpartum patient, but they do call every single postpartum patient. And they ask, how's it going since you've been home? Do you have any questions? Do you have any concerns? And if the patient doesn't, then that's the last they ever hear from the public health nurse. But if the patient says, we haven't slept in the 3 nights we've been home, baby's not eating, baby's not peeing or pooping, or baby's this or baby's that, then the public health nurse will come visit them and help them with whatever their problem is. And if needed, an earlier referral or an earlier appointment with the doctor. And then there's a little section on safety for the nurses doing public health visits.
If during the screening or whatever, if somebody came up higher risk for postpartum depression, at what point do you address that? If
So we assess all patients upon discharge, like rate them as far as their postpartum depression risk, and then of course pass that information on to the physician who may put them on something or may do an earlier follow-up. But we educate both the mom and the dad before discharge, and we even, or the partner or family, we even let them know, like, if you're concerned, maybe mom's not concerned, but if you're concerned, then you need to call us. And then so, of course, at a postpartum visit or public health visit, if the public health nurse was concerned, then she would also refer as well.
How long does postpartum depression go on? Because
Like
you
6
just-
months and then you shoot your child?
Yeah,
That's what I was just so, it was out of my mind.
So postpartum, so there's kind of different levels. Postpartum blues, and postpartum blues are just you cry when you see the toilet paper commercial on the television. Postpartum depression is a real depression and needs to be medicated. And then there's postpartum psychosis. Okay, so that could. I mean, there have been claims postpartum depression has been claimed up to 12 months after birth. Or psychosis, is that what I said? Postpartum psychosis.
I'll just share my personal experience. Like, I didn't realize I really had anything going on until my son was 9 months old. And then just realized, like, clearly there's something not quite right.
Right.
Obviously was not wanting to harm myself or harm him, but just mentally just was not, just not all firing on all cylinders
Right.
all the time. So.
Right. So I've heard stories up to 12 months. So sometimes the doc will just prescribe a little bit of B12, or sometimes they'll put them on antidepressant medications. So,
Did you need medical or anything?
Yeah, people can have medication.
And it helped,
Oh, yeah.
like,
Yeah, pretty well. Pretty much immediately it was like, oh, this is what normal feels like. I kind of
Right.
forgot about
yeah,
that.
and see, that's one of the things is with the mom. So it's not necessarily that she's in denial, which she may be, but she's just so used to feeling so sluggish that it just starts becoming normal. And then the people around her, her significant other or whoever, starts noticing, no, this is not normal. And so they do feel calls from the significant other thing, or they attend the postpartum 6-week appointment or something and say, yeah, she's not right. So
Well, and I think a lot of women are kind of like, I'm just so tired because I'm up feeding baby all the
Yeah.
time and changing diapers and all of that stuff. And it's just kind of like, you expect that to even out.
Yeah.
And you're kind of like, okay, when it doesn't even out, then it's like, all right, clearly there's something else going on.
Right.
Here. So,
Mhm. yeah.
And that's a change for yourself as well.
I actually stayed on antidepressants through my second pregnancy, so it didn't happen with her. But, yeah.
well, and I think too, like, the whole time you're pregnant, people are, oh, your life's gonna change, it's gonna be so away, you're not gonna get any sleep. So you hear all these like negative stories, and so when you're like struggling with a baby, you don't know, if you say something, people are gonna be like, oh yeah, having kids is hard.
Yeah.
So.
Yeah.
Yeah, having a big black eye hurts too.
Stigma.
Doesn't it? Doesn't it hurt? There's a little section on maternal and family assessment that you can read. Breastfeeding. Pull the shades. No, so some.
See your cell phone, take both sides.
Right. So some problems with breastfeeding. First one being nipple soreness. So when women first start breastfeeding, yeah, they're going to be a little sore. This is a new thing that's going on with their breasts, and it kind of feels sore until they get acclimated or used to this deal. But one of the big things that causes soreness that doesn't go away is incorrect latch. So latching is very important. Positioning is very important to prevent sore nipples. So we need to address the latch and correct the latch. Now mothers can use their own milk to soothe their sore nipples. We've got lanolin cream that we hand out, peppermint gel, protective shells, or nipple shields. Now protective shells are just a hard plastic clear shell that you put right over the breast, and it doesn't touch the actual breast. It's just like a cap with a big hole in it, and it fits right over her breast, so nothing touches her nipple. So it has a chance to stay dry and heal. The nipple shields are look like little nipples. This little flexible shield. It completely covers the nipple. So it looks like an extension, a nipple extension maybe. And these are helpful for babies to latch onto, and it decreases the trauma to the nipple, so that her nipple can heal up. Okay, we don't want to use these nipple shells throughout our shields throughout the whole entire breastfeeding lifespan. Okay, just until we get her soreness healed. And then definitely want this lady working with a lactation consultant. So then sore nipples do progress to cracked nipples if that latch has not been fixed. Babies can traumatize that nipple. It can cause cracking, bleeding, blistering, bruising. I've seen nipples that I'm like, oh my God, they just look like Hamburg. So we need to fix the latch, okay? And we need to make sure that babies aren't latched onto the nipple. They need to be latched onto the areola. Okay, so all the same interventions. She can begin nursing on the breast that is less sore, less cracked, but she's still going to have to get on that other breast. Okay, and the nipple shields are actually really good if she's cracked. Okay, because it really helps decrease the trauma and pressure on the nipple.
Is it usually latch?
Huh?
Is that usually the problem?
It's usually the problem. Most always the problem. The other problem that can be is if you have a baby that's nursing and actively sucking, and you say it's time to stop, and you pull the baby up the nipple. Okay, that will cause trauma and breakdown to the nipple. So we instruct the moms to put her finger in the corner of the baby's mouth until the suction is broke. The other thing that happens, not only with latch, is positioning. So if baby isn't positioned correctly, especially if baby has to turn their head to the nipple, then as baby tries to relax their head, they start pulling on the breast. And then the other thing is, if mom isn't got good support around her to hold this baby while she's breastfeeding, and her hold starts to tire and relax and drop, and the baby starts dropping and basically hanging like a monkey on the boob, that will cause problems. Okay. So
The invention of the boppy.
the boppy and 20 body pillows or whatever you need to do. So of course she can take some Tylenol or something before nursing to kind of help until those get healed.
I have a quick question about, so the more they nurse, the more milk production, right? Does that have to be both breasts? Like if the baby prefers, or it's easier to hold them in one position,
Yeah.
and so you end up milking one side more than the other,
Yeah.
will both breasts actually be stimulated enough that they're both producing more, or
No.
just the...
So they need to switch breasts. Now with feedings, I really like moms to get in the habit of feeding on both breasts each feed. Sometimes that doesn't happen, but it's an awful good practice. It's not a good routine to be like, well, my baby nurses 20 minutes on this side and she's happy for 2 hours. Okay, you're gonna walk around, like this, because this boob is gonna start getting really heavy, and I'm gonna look at you and say, you need some more air in the other tire. Okay, so I just like them to get in the habit of nursing on both breasts at each feed. If once in a while it doesn't happen, that's fine. But the other thing is, we switch breasts each time as well. So I think I'll cover that here soon. So if at 10 a.m. I start breastfeeding on my right breast, and irregardless of whether I end with the left one or not, then at noon I'm going to start on the left one. Okay. So we switch, and we give each breast a fair turn,
Even if they're cracked?
even if they're cracked. Something, if it's bad enough, we have just pumped that breast.
Is that easier?
Yeah, it's less traumatic on the nipple if the cracking is bad enough. But all right, so breast engorgement is when the breast gets so full that they're literally hard as rocks, and virtually impossible for the baby to latch on. Because literally, it's like trying to latch onto the wall. That's how hard boobs can get, okay? And it's very painful and uncomfortable for mom. And breastfeeding moms do encounter engorgement, especially if they're not feeding long enough on each side and often enough each day, or as many times as they're supposed to each day, okay? If they go for too many gaps, like we can have a 4 to 5 hour gap at night to help promote nighttime sleeping. But if she gets close to 5 hours before baby wakes up and eats, she might wake up and say it's time, because she's going to feel that engorgement. Okay. But if that does occur, then mom just needs to express some milk so the breasts are soft enough for baby to latch on. Okay. She can do some warm compresses before nursing that will help soften the breasts. And then if she's having routine engorgement and her baby is nursing long enough and her baby is nursing often enough, then she might want to do cold compresses after the feeding, just to kind of constrict everything a little bit and make it a little harder for those breasts to fill. Okay? But usually that's not a routine. If we're feeding good, that's usually not something that she's going to encounter all the time. And then a nice supportive bra, of course. Now, plug ducts sometimes happens. And so we have our milk alveoli, or our milk buckets, all the way around our breasts. And then we have the duct system that transports or lets the milk drip down to the nipples, okay? It's the vein system, if you will, or the plumbing, whatever you want to call it. Those tubes that go down to the nipples. So what happens is there was some milk stasis in that section, and it kind of tried to dry up. I mean, it's not going to dry up like crusty dry up, but it creates a plug, and so nothing will pass through there. And as big as that plug gets, you can feel it. It feels like maybe a little pea or a little cyst, might be painful, and no big deal. So we latch baby on the breast, and as the baby's nursing, we go from above the plug, massage down through the plug towards the nipple. That will just help move that along, okay? And it's fine if baby gets that. It's just milk, okay? So anyways, heat massage, warm compresses will help move that through. If she starts having starts having this regularly, and especially if it's in the same place on her breast, we might want to decide, are we doing something to cause that? Like if she's always carrying the diaper bag in the same place, that's putting pressure on those ducts or something, okay? Try to figure out why this keeps occurring. This is another reason why when we have women breastfeed, that we tell them to switch up the positioning of the breastfeeding. So when we did the cradle hold or the cross cradle, and switch it up with the football hold, that the way the baby's nose and chin are pointing, then those ducts in that line, those milk ducts in that line, are going to be emptied more thoroughly than the other ducts. So if you move that baby's line, then you get more complete emptying of the breasts each time. All right, and I don't know why my mastitis slides are gone, but mastitis is an infection in the breast tissue. It's painful. It can be red. That area in the tissue, breast tissue, can be red, hot, inflamed. She can be having a fever. She can ache all over. She can feel like she has the flu, and she's going to need antibiotics. Okay, and then it's fine. Okay.
Did the baby just go on formula while she was on?
No,
antibiotics,
she can let the let the doctor know, and he'll prescribe an antibiotic that's safe for pregnancy or breastfeeding. Back in the day, we used to pump and dump, but okay. Anyways, so breastfeeding mothers, we don't want them drinking anything at all, ever, but they can if they're gonna have a drink. They can have a drink at least 2 hours before the nursing session, and just one. I mean, not the whole keg. Okay. So and they can pump and dump if they want. If they've got breast milk stored, they can pump and dump and feed the baby the stored breast milk. We just don't want to make it sound so okay, because we don't want, there's some mothers out there who have a problem with alcohol, so. And definitely anything over the counter and prescription, she needs to make sure, especially if she has a doctor managing some other condition, like she has maybe she has a heart doctor or an asthma doctor or an epilepsy doctor or some other doctor. She needs to make sure that they know she's breastfeeding and for them to prescribe something that's safe for her to take while breastfeeding. But make sure they know over-the-counter medicines aren't necessarily safe for you to take. You need to let people know what over-the-counter medicine you're taking and see if that's okay. Can you guys think of one common over-the-counter medication that would probably be absolutely the worst thing to take while you're breastfeeding? Does anybody know? Okay. Anything that dries up your sinuses are going to, I'm using this as a hint. This wasn't really what I was going to, but anything that dries up your sinuses is going to dry up your breast supply. So if she has a cold, stuffy nose, and she thinks she's going to go out and get some Sudafed or whatever to dry up her sinuses, she might also dry up her milk. Okay? So it's not that it's a problem for the baby to get that, but it might be a problem for her breast milk supply. So, so she needs to make sure she checks with the pediatrician or obstetrician. All right. So weaning from breastfeeding. Weaning can happen right now, today. You're done. I'm through. We're not breastfeeding anymore, period. That's fine if that's her choice. She's going to go through engorgement. It's going to be very uncomfortable, miserable for 2 or 3 days. Okay, baby might be a monster for 2 or 3 days until they decide, okay, I'm starving to death. I'll finally take the bottle. Okay, but weaning is a more humane way to do it, and we're not asking for this to go for months and months and months. But you know, if for a couple of days she substitutes one breastfeeding for a bottle feeding, okay, and then and day 3 or day 4 she substitutes 2 breastfeedings, okay, within a couple of weeks she might get this done, okay, and then it gives baby time to adjust to using the bottle, and it will decrease her terrible engorgement experience. So it's the slow method. All right.
I thought babies preferred bottles.
Huh?
I thought babies preferred bottles because they got it like.
If they're easier, bottles are easier. Bottles are easier because it takes more strength, one, to breastfeed, and it's a totally different technique to breastfeed. Okay.
Oh, so that's why baby might be resistant.
Right. And so when you put a boob in a mouth, especially before her mature milk comes in, babies have to suck several times just to get a taste of breast milk. Okay. Whereas I can hold the bottle upside down, baby just needs to open their mouth and milk's going to go in their mouth. Okay. So it's just easier. But once they get used to breast milk, you will have a hell of a time getting a baby on a bottle. Sometimes it's impossible. And if the mother, the breastfeeding mother, is trying to introduce a bottle, it's near impossible. The baby knows this is mom. The baby knows mom has a boob. So she won't take the bottle. So you need someone else to start offering the bottle. All right. All right, postpartum hemorrhage. So just to touch here, early postpartum hemorrhage is within the first 24 hours. So she's in the hospital. But we've already sent this gal home. She is still at risk for postpartum hemorrhage. Okay? Late postpartum hemorrhage can occur up to 6 weeks after delivery. Okay? And the reason why that is that uterus is not healing the way it should be. Okay? And so then it starts bleeding. Now, a general rule for postpartum hemorrhage is if she had a vaginal birth, if she has anything greater than 500 cc's of blood loss, then she's had a postpartum hemorrhage. For a C-section, it's greater than 1,000 cc's, and for a repeat C-section, it's greater than 1,500 cc's. Okay? Now the thing with postpartum hemorrhage and a healthy 20, 30, even 40-some-year-old woman without any health problems who went through pregnancy, so now they have an increased blood volume because of the pregnancy, they will tolerate a huge blood loss before they start showing signs and symptoms, and then it's quick. But they can lose up to 2 liters of blood before they start showing signs and symptoms. But we don't want to wait until she's lost 2 liters before we start doing anything. The signs and symptoms that she can show is increased heart rate, decreased urine. Yeah.
I'm sorry. How are you measuring that? Are you weighing the peri-pad?
Yeah.
or-
So if you have a woman that you are noticing, so right after delivery, especially, we're checking this woman every 15 minutes. We're checking her fundus and her blood loss. If we're starting to notice that she seems to be having more blood loss than we think is normal, because we don't automatically weigh pads, okay, for a normal routine, not hemorrhaging type person. But if we're starting to notice that, then we start weighing pads. We have a postpartum hemorrhage cart. It has a little scale on it, and we know the dry weights of our pads that we use in our department. And so we take the whole mess of it, and we put it on that scale, and we weigh it, and we subtract our dry weight. We weigh it in grams, and grams equals cc's. So whatever your grams is, that's how much cc blood loss. And then you start keeping track of all the weights. But if we were on lunch break and wasn't paying attention to our person, or if this person called the doctor's office, and so she has increasing heart rate, dropping blood pressure, and urine output, then she is now succumbing to her blood loss. Okay. So it affects her cardiac output, therefore it affects her organ function, and then brain being one of those organs, she starts circling. Okay, so here's all of the possible, not all, here's some possible reasons for postpartum hemorrhage. So if you can just imagine a normal healthy uterus, every minute 600 cc's of blood just flows through the uterus every minute. 600 cc's of blood, okay? And so if she's hemorrhaging, you can see how we can get to a postpartum hemorrhage within minutes. Anyways, so the reason why is one is overdistension of the uterus. So start thinking about, if you have this woman with multiple babies, twins or more, and she has a hydramnios, so lots of amniotic fluid throughout her pregnancy, if she has a very super huge baby in there, macrosomia, a dysfunctional or a prolonged labor and oxytocin use. Okay, so oxytocin is our drug of choice for postpartum hemorrhage. But why would oxytocin be one of the reasons why we're contributing to postpartum hemorrhage? Huh?
Isn't it because it's already it's like contracting and sending blood?
So what happens, similar to dysfunctional or prolonged labor, oxytocin use, it's not the normal routine use of oxytocin. It's the labor that goes on for 24, 48, 36 hours. We're running Pitocin on this woman, and we're keeping this uterus contracting and contracting and contracting and contracting. This uterus is a muscle. It will eventually fatigue. Okay? So if we're overdoing it with oxytocin during labor, if we have a dysfunctional labor where this woman is contracting and contracting and contracting and not dilating, not getting to the end of her ready to push stage, and that uterus is just going to town and it's going to eventually fatigue. Okay? So if it's fatigued during the labor, then it's going to be fatigued postpartum. So it won't want to contract postpartum to control her bleeding. But oxytocin use, the normal use of oxytocin is really not an issue. I mean, we use oxytocin every single day on just about every single patient because we're a hospital and that's what we do. And we have people deliver and they don't all go to postpartum hemorrhage just because we use oxytocin in labor. But if this was my patient and we were on day 2 of her induction using Pitocin, then I know that if I'm going to be the nurse at delivery or I'm going to pass on to the next nurse, hey, listen, like we've been using oxytocin for 24 hours, so just watch her after delivery. That uterus might be tired. Okay? It might be completely, all the oxytocin receptors on the uterus might be saturated. You can't do any more, any less. It's not going to work. Okay? So it's just something to keep in mind. So a grand mal tip. So why would a grand mal tip be at risk for postpartum hemorrhage? Grand mal tip being she's had lots of pregnancies. Yeah. So you can stretch the rubber band so many times before it does not retract anymore. Okay. Anesthesia, prolonged third stage. The third stage being what's being delivered at third stage? Placenta. Retained placental products. So it's just their blood pressure issue, okay? And so her poor vasculature to begin with. So, you know, she's at risk for bleeding. An operative birth, Asian, Hispanic heritage. What should be up there is redheads. I'm not kidding. Redheads bleed. Okay. Lacerations of the genital tract. So when we do episiotomy, of course, we know where that is, and we stitch that episiotomy up. But if she has lacerations, especially if they're deep in the vaginal wall or even in the cervix, the physician might not see those. He might miss those, and those will continue to bleed. Okay, so that could set her up for a hemorrhage.
What would cause a laceration?
The baby. A big baby coming down, ripping shit up.
No, I don't want to go.
Yeah. If we, and this is why we like to do vaginal exams on women that say I'm ready to push, is I've had women that were ready to push and they were only 8 centimeters. If I would have let her push, she would have tore her cervix. Okay? So that's why we like to do vag exams when women say I'm ready to push. Retained placental products. Hematomas. So the vaginal tissue, the perineal tissue can hold a lot of blood. Okay? And you're not seeing the blood because she's not actively bleeding onto the pads. She's bleeding into her tissues, and she can hold a whole lot of blood in there. I'm sure she can hold a minimum of 500 cc's in her perineum and vaginal tissues. So we need to be checking her bottom. All right, so all these are...
Is that just going to look like edema kind of?
Yeah, it's going to look like edema. It's going to get bigger and bigger and bigger. And she's going to start complaining of more and more pain. Instead of wanting ibuprofen for a vaginal delivery, she's asking for IM morphine. And you're like, oh, that's a lot of pain. I'll check that out. All right, so these next few slides just to kind of describe the normal changes, the healing or the return to pre-pregnant changes in the uterus. It decreases in size in a process called evolution. Involution. So that initial layer inside the uterus, it's sloughed off just like the endometrium is during a menstrual period. And then there's that inner layer that kind of just regenerates and becomes the new endometrium. Takes 3 to 6 weeks. But if this process isn't working like it's supposed to, then she's going to start bleeding postpartum at home.
Will it still get that wall if she's breastfeeding? Because I thought she doesn't have her period, so that I thought the endometrium doesn't.
No, this is this is right after delivery, that decidual layer that was in with the uterus, in the uterus when she was pregnant. So that layer is getting sloughed off, okay? And then the inner layer is what builds the new endometrium. And so after 3 to 6 weeks, when all that has been sloughed off, then the bleeding will stop as far as her normal postpartum lochia bleeding. So then when menorrhea starts back is dependent on whether she's breastfeeding or not. So if they're not breastfeeding, usually menorrhea and ovulation come back.
If she is, though, will that
If she is
endometrium not come back until?
No, the endometrium layer will still come back, but it won't start proliferating like it goes through when we go through the menstruation cycle and waiting for implantation and then sloughing off and having a period. It doesn't go through those stages.
So it's just a light layer rather than
Right.
the.
Right. It's just the new layer sitting there waiting on stuff to tell it what to do. So the placenta site, it heals a little differently. Oh, we're done. 5 minutes. It heals a little differently. The placental site is really important because when the placenta was there, those vessels in the endometrial lining underneath the placenta and the placenta, so those vessels are larger so that we can have all this good nutrient and oxygen exchange between the baby and the mom. But we don't want these big, large vessels now. The placenta's gone. We don't want these big, large vessels staying there. So this process is called exfoliation. So they clot off. Those large vessels are obliterated. They kind of go away, and then just the new vessels come back the way it was before she was pregnant. Okay, these are smaller vessels. But if something is happening where these larger vessels aren't getting obliterated, they're not getting clotted off, and then she's going to be bleeding from those new vessels. Okay, but anyways, the rest of this process, this whole process, is in order for that area where the placenta was to regenerate like new, not scarred. Okay, because if it scars, then the next placenta can't go there. Okay, so we don't want all these scarred areas in the uterus, because if this woman wants 20 kids, she needs lots of areas. This process prevents scarring.
So this process here is like the biggest contributor to the lochia afterwards?
No, not this one. It's actually more just the whole uterus, the sloughing of that old pregnancy uterine lining, and but I mean we do get a lot of blood from here, but it's not the biggest part because we want these to clot off and degenerate, and then the new vessels to appear. All right, so I'll just tell you that, so the bleeding that she does have after birth, we call that lochia. We don't call it menstruation, it's lochia. And the first couple of days as she's in the hospital, it's rubra, red rubra. And then for the next week or so, it's pink serosa. And then after that, it changes to white until it disappears. And that's called the alba. Okay, so it takes up to 6 weeks for all this stuff to occur. Our process for helping a boggy uterus that doesn't want to contract is massage, of course. Here's a manual compression, and yeah, this is uncomfortable. Here's manual removal of placental products.
Do they actually do that?
Actually do that.
I think there's stuff DNC or something.
Well, because then that's surgery.
Right.
She's laying there on the bed, her epidural's still running. Let's just go in there and scrape the rest of that out real quick.
She's dilated at this point.
Yeah.
Still.
Yeah.
It's pretty. I guess the hand's pretty small compared to a baby.
Yeah, but it's still not comfortable.
I believe that.
Here's our drugs. These next two slides tell us our drugs that we give for uterine atony. Oxytocin or Pitocin is our first line drug. Okay. Our second line drug is not necessarily second line. Another drug is Methergin. It's an IM injection to help control bleeding. I've never used Ergotrate, but that's a possibility. I have used Hemabate. It's another IM injection. But the second line, and this is why I corrected myself, is because we really like using Cytotec. Okay? And we give 800 to 1,000 micrograms. And I'm pointing that out to you because Cytotec is delivered to us in 100 or 200 microgram tablets. And for postpartum hemorrhage, I'm giving up to 800 rectally. I'm sorry, point that out, rectally. Okay? So that's why it's a big hairy deal. You're not just swallowing a bucket of pills. You're not swallowing a bucket of pills. Okay, so go ahead and read through these slides on infections, endometrial infections, signs and symptoms. Prevention is good hygienes. It says sitz baths here, but she can take a small warm tub bath for her perineum.
Testing purposes, though.
But not for testing. Yeah, I won't put that. I'm taking that, kicking that out. So a UTI. Okay, so here's your signs and symptoms for UTI. Again, good hygiene. Emptying the bladder regularly. Here's my slides for mastitis. Yay. Let's. So we talked a little bit about the hypocoagulability of pregnancy, so we need to instruct them about what to look for a DVT. Okay, you can look through these slides. Homan sign, everybody knows Homan sign. Don't do Homan sign because you'll dislodge that clot. But you can feel her calf. It could be warm. You can look at her calf. It could be red. It could be larger than the other calf. And she can say, my calf hurts. So you don't need to do a Homan sign. But anyways, here's, so our treatment, Lovenox during the antepartum period, okay? Heparin during the intrapartum period. So when she's in labor, she's getting a heparin drip, okay? And then usually on Lovenox after postpartum, postpartum, but they can also be on Coumadin.
That's routine?
Nice.
No.
It's not routine. It's if she has a DVT or even a clotting disorder. Okay.
So they don't usually use heparin during pregnancy, but in the interpartum period?
Not in the antepartum period. Heparin is just for the labor. Huh?
But why? Wouldn't that create problems?
In the labor, they have greater control with the heparin in labor than they do giving a 12-hour Lovenox. Okay, so if I had to stop the heparin, if I had to titrate the heparin, if I had to turn it up, turn it down, discontinue it, if I give a sub-Q injection of Lovenox, I have no ability to change that besides giving vitamin K.
So like it's, oh, you can use vitamin K for Lovenox?
It's a vitamin K is
I know they use it for Coumadin, but I didn't know that Lovenox.
well, I'm assuming. I don't know. Yeah, we just use heparin in labor.